Sure. All right. If there's anyone out in the lobby or anyone else getting food out there, we're going to start. This is the presentation with endocrinologist Tala Dajani regarding growth hormones. And my name is Sarah Shea. I am a WSS parent. My little girl Ivy is 6 years old. And we started out with an endocrinologist in Asheville. I had a lot of questions regarding possible use of growth hormone and was having a lot of difficulty getting Medicaid to approve it. And then pandemic happened, which didn't make things easier. And then the endocrinologist we had at Mission Hospital in Asheville left, and they had no endocrinologist. And I was like, wow, this is just a bummer, and this is not going anywhere. And then I got a letter in the mail from Mission Hospital finally toward the end of pandemic, and they were like, we have a new pediatric endocrinologist, Tala Dajani. And I am excited to introduce her here today because this woman has gone to bat for us. I walked into her office in Asheville thinking that I was going to have to really explain my role as a single parent, and I was going to have to explain Wiedemann-Steiner syndrome and do all this stuff. And I started talking with Tala, and I said, tried to explain a little bit about Wiedemann-Steiner syndrome. And she said, oh my gosh, I'm also a special needs mom. My kid is on the spectrum, and we have so many things in common. And we started comparing and contrasting similarities about our kid. And she was like, yes, all the research I've done tells me that growth hormones are helpful for the Wiedemann-Steiner syndrome population. And I said, I know I've been having such a hard time getting Medicaid to approve this and explaining everything. And she goes, why don't I just handle that for you? And I was like, oh, okay. And she did. And she went to bat to Medicaid and she got everything approved. And we are having an extremely successful experience on growth hormones. Ivy's been on them for about a month. I'm seeing improvement in her GI and bowel function. I am seeing improvement in her fine and gross motor development. It's not a lot. Again, it's been a month, but I've seen her grow a little bit already. So we're going to stay on growth hormones and continue to give, feedback and document how Ivy responds to them. But we could not have done it. We would not have been able to have this successful experience without the help of Dr. Dajani. And I'm so grateful that she is now part of our team in Asheville. So without further hesitation, please welcome Dr. Tala Dajani, Mission Hospital in Asheville, North Carolina. Thank you.
Thank you so much for that wonderful introduction. It's my pleasure to be here today. And my area of expertise is definitely in WSS. It's in kids of special needs. And there's so many orphan disease or diseases that you can't do large studies on. And so I really like to help those patients and do the research and learn. And it's a learning process for me, and it continues to be so. I do want to let you know that my slides I've used some graphics that are copyrighted, so they're not for reproduction. Anything I speak about you can reuse, but in regards to the graphics, I don't own them. So please don't redistribute those. But if there's any way I can be support with helping you, whatever you need to distribute. But I just wanted to let you know that I'm using them for educational purposes only. I have a son who's 15, who has been diagnosed with autism spectrum, and even as a trained endocrinologist and pediatrician, I've had to advocate and navigate the system for him, and it's the best thing that happened to my practice and as a provider, and it's taught me to look at things differently. So I just approach things and I just keep educating myself and learning and trying and trying. And that's my one promise to my patients. I may not be the expert in the field, but I will do my best and learn, and we will learn together. Where? I like to start with some mindfulness, and this is just a good time to open our brains for learning and just take a nice deep breath, and so you can take this information in and kind of go through it and see what applies to you and what doesn't. And I just want to talk a little bit about body stigma. One of the things that I helped teach at a medical school last year in Arizona. I came from Arizona, and one of the things I really talk to my patients, but really my students about as well, is that everybody's beautiful however it is they are. The day they were born, they were beautiful babies. And I really don't care what height or weight anybody is. I just want them to be healthy and their best. And the one thing I do want to fight against is any kind of stigma having to do with the body size and shame. And just to know that we are all perfect, and your child is perfect as they are right now. So my goal is not to change your child, but to help them be the best they can be. So today I want to talk to you first. We're going to hopefully, I do learning objectives as part of my previous training. And so what is short stature? What does that mean? And what's the difference between short stature and actual growth failure? What will an endocrinologist order? What is ordered as part of a short stature? And I want to go over the current literature and what the current recommendations is in WSS. And then what are the risks and the benefits? What kind of things do you need to think about? What's known out there and what's not known out there? And I think it's about taking in that information and making the best decision for your child. And there is no one size fits all. So what is short stature? I'm going to go over this a little bit more, but using a stadiometer and having accuracy with the measurement is extremely important. So children under age 2 will be measured laying down. Once between age 2 and when they can stand, we like to see them standing. And that's going to be a little bit of a difference, standing versus supine or laying down height. So we have to take that into account. But when you are looking at the growth charts, particularly under age 2, they're all laying down. None of those are standing. And so it's important to compare apples to apples. Also, any inaccuracies with the measurement will make a difference in accuracy and precision. And that's really extremely important if we're going to be making decisions on the child's growth based on how we measure them. And so I only use the measurements used in my office with my staff who's been trained, and we have a stadiometer that is calibrated frequently and checked so that we are doing accuracy. And these are some of the things we train our medical assistants or anybody who's going to help us measure, or when we measure. So I can't emphasize the importance of accurate measurement. And these are some of the tips we give people when we're doing that. Short stature is defined as a statistical thing. It's any standing, and it's usually, we will define short stature after age 2 or 3 officially, but it's a standing height of more than 2 standard deviations below the mean, or less, 2%, 2.5% or less when you look at it. Growth failure is very different than short stature. Growth failure is the lack of growing versus short stature, and growth failure usually indicates something wrong is going on. Why is the child not growing when they should be? Versus short stature is just saying where their stature is, and it's not necessarily. There are multiple short stature diagnoses or normal variants that I'm going to talk about. So this is, you have to memorize everything on this slide, and I'll test you at the end. Just kidding. This is just letting you know what growth hormone does. Growth hormone is produced from the pituitary. And if you took your 2 fingers, you put your one finger on your temple and one on right between your eyes, where those 2 meet is where your pituitary is. It's about the size of a pea, and it's the master gland in the body. It produces growth hormone. Growth hormone is in it, and the pituitary kind of looks like this kind of double lobulated thing here, almost like a tonsil, but it's much smaller. This is what it is in the brain. It's protected by a bony structure. It produces growth hormone, and the first thing growth hormone does is goes to the liver, and it causes the liver to lose insulin-like growth factor 1. Together, they go to do their work. So growth hormone and IGF-1 will go to the growth plates, which I'm going to show you later, and will use amino acids or protein to help yourself grow. So you'll lead to, and will release glucose from the liver so the body can have energy to grow. It's generally produced in stage 4 sleep. So kids do need to sleep to grow. And it allows the muscles to get stronger and grow themselves as well. Lets the muscles take up glucose. It also helps with fat breakdown and uses fat for energy, and it leads to growth at the growth plates and growth in every organ, everywhere that you need growth. It really does affect everything. When the level gets too high or the body reaches a level, you get negative feedback. And so these are some of the negative feedbacks and leads to the body. So the body regulates the growth hormone according and what the pituitary is constantly measuring. And it's released in this pulsatile fashion. It's stimulated by sleep, extremely important, sleep, exercise, stress can do it as well. And it's inhibited when your growth factor or the growth hormone levels get too high and the body says, the pituitary says, okay, I need to regulate this. When a child is not growing, what's going on? So the top 2 normals are constitutional growth delay, and that's a typical late bloomer. These are the people who grow late into high school where everybody else is done growing. And that has a tendency to be genetic. So you do see that with families. Of course, there's familial short stature, and that's kind of the poker of genetics. You may have grandparents who are tall and your parents are not, or other grandparents are not, and you can have 2 children in the same parents, same family with completely different final heights that are both normal. And so that's really on what genes are being expressed in you. Our combination of late short stature and late delay, growth delay. Nutritionally, if you don't have enough calories, the body is not going to produce growth hormone, is not going to let your body go through the growth process. And that makes sense because that's going to put a lot of stress on the body and it's going to use that energy to move and be alive, for your heart to beat. Any kind of bowel issues, chronic inflammatory bowel disease, Crohn's disease, any malabsorption, celiac, which is the gluten allergy, will all prevent growth hormone from being secreted. And that is not because it's a growth hormone problem, but because there is an inadequate calories. Likewise, growth hormone will not be produced properly unless your thyroid is producing the right amount of hormone. Your rest of the pituitary helps control the adrenal gland to produce cortisol. It has to be produced for you to produce growth hormone. You can see issues with growth if there is too much cortisol, which is a condition where the adrenal gland has a tumor and produces, it's called Cushing's syndrome. Our early puberty will lead to a big growth spurt, and then your growth plates will close early and you won't end up the height you're supposed to be. All organs have to be working, your heart, your lungs, your liver, your brain, everything has to be working to do. Growth is growth is almost the top performance. The top performance is fertility. If you're fertile and things are working, then everything has to be working. Your body has to be able to handle that. Likewise, the body is, if you're ill, even when kids are sick in the ICU or they have a temporary illness, or when they get cancer diagnosis and get that treatment, the body will stop growing. You'll get what's called growth arrest. And if you give growth hormone to those sick kids, you'll only make them sicker, because that's a natural, healthy compensation so that the body can use all the energy to heal or to treat the cancer or infection or whatever's going on. So it's very normal for the body to produce growth hormone when time is right and to pull back on it when the time isn't right, when we need energy for other things. Kids who don't have good growth in utero or have intrauterine restriction, or something is wrong with the placenta, might be born small, or exposure to toxins in utero like alcohol or like fetal alcohol syndrome will lead to that, prematurity. And I'll talk a little bit later about that because there are some indications for growth hormone with those kiddos. And then kids who are born with a genetic skeletal dysplasia, this is like achondroplastic dwarfism. And they may have they may have shorter legs and a bigger torso. That's considered a disproportionate short stature. And the metabolic goes with the organ failure. If your kidney's not working, your body's not going to produce growth hormone. If your heart can't beat or your lungs are not letting the hypoxic is lack of oxygen, then you're going to see those issues. And any inborn errors of metabolism. So if your body can't handle sugar or your carbohydrates or your protein or the fat in your body, then you're going to have those issues. In regards to syndromes and chromosome defects, there's a wide variety of issues that can happen. You could have a true growth hormone deficiency. You could have growth hormone resistance. For example, you're producing growth hormone, but the body's not responding to it. And then growth hormone needs growth factor from the liver to work. So you could have a growth factor deficiency or the growth factor resistance. It's binding its receptor and trying to do its work. It's just not working. In regards to what we're going to focus on today, this is kind of a big representation of all the potential growth, short stature. So within normal variant is familial and the late bloomer that we talked about. And then in pathological or worrisome growth hormone issues, it could either be a disproportionate short stature. Rickets is a vitamin D deficiency, so the bone's not getting what it needs, calcium and vitamin D, or skeletal dysplasia like achondroplastic dwarfism, where genetically there's a problem with the bones growing. In regards to chromosome and genetic syndromes, they're going to be prenatal onset. They're going to be something that's happened from the time you're in utero. And so those are the ones we're going to focus on, and that's where a WSS syndrome is going to be. Postnatal onset if a kid doesn't get proper nutrition. And unfortunately, if a kid doesn't get hugged and loved, they don't produce growth hormone. That's called psychosocial dwarfism. We diagnose that, unfortunately, in lots of kids in foster care, or sometimes kids have been in orphanages where they don't get parenting or the kind of what they need. And that also is a situation where the body will not produce growth hormone. Kids have to be touched to produce growth hormone. There's a whole touch related to it as well. So normal variance, we talked about one thing that you should know. We talked about short stature that's in the family or constitutional growth delay. But what we didn't talk about is a lot of babies might be born large, or, my 95th percentile. Does that mean they're going to be over 6 feet tall if it's a male or something like that? And that is not true. All children will choose their percentile of growth by age 3. And they can do, they can go from the 90th to the 30th to the 20th percentile from birth to age 3. And that is a normal physiological deceleration of linear growth. In other words, you're getting to your genetic potential. You may not be born exactly where you're going to be. So the first 3 years don't necessarily tell you what height that child is going to be. We grow the fastest in our whole life in utero, but after we're born, in our first year of life, we grow 10 inches in the first year of life. Think of that baby being born, you hold it, and then now it's going to be walking by around 12 to 16 months or later. But that first year, they're going to grow 10 inches. In the second year, these are averages, they're going to grow 5 inches. In the third year, 3 inches. After that, kids will settle into what we call prepubertal growth, and they'll grow about 2 inches a year. Once we go into our pubertal growth spurt, you can have 3 to 4 inches a year. I put 4 inches a year as a way to just remember, but it's 3 to 4 inches a year. And girls are going to have their growth spurts before boys. I'll show that to you. And because boys grow an extra 3 years is why males are taller than females. So this is looking at your growth velocity, what I just showed you in numbers in a chart. And so you can see in that first year of life, it's so important. In utero is probably the most important. Now the first year of life, we're going to get that first 10 inches. We're going to need really good nutrition, happiness. The mental health actually matters. Getting hugs, being in a safe place. Psychosocially, social determinants are extremely important here. And then the rest of the hormones in the body, particularly thyroid hormone and cortisol, need to be working. It's really important. And then as you can see, girls are going to do their big growth spurt between age 10 and they peak at age 12, and then they have their period and they grow for a little bit longer and they're done. And then males are going to reach their peak 15 to 16. And that's the typical. If they're a late bloomer or constitutional delay, they'll do it later than that. And they will also have a bigger growth spurt than girls in general. So you can calculate your midparental height, and the closer the parents' heights are to each other, the more accurate it is. The further away the two parents' heights are, the less accurate it is. So I'm 5'4" and my husband is 6'4", and my father is 5'7". My kids could be anywhere in that. We're really big difference in our height, and all of that would be normal for us. So the wider the span between the parents' heights, in general, you average the parents' height. For a girl, you're going to subtract about 2.5 inches. For a boy, you add 2.5 inches. And unfortunately, that's plus or minus 4 inches. So it's not particularly accurate, but it gives you an idea. And we're not particularly, doesn't pinpoint exactly a height. This is kind of that late bloom that the boys in middle school are going to be shorter than the girls in middle school because they're done growing. That's the awkward 7th and 8th grade and 9th grade time where girls are taller and already may have bodies of women already completed and started their menstruation. Under it is all the information I need I start data collecting. I'm putting the puzzle together, what's going on with this child. And I'm not going to be able to tell you everything in one visit. I'm going to start to get to know you, get to know your family, get to know your child, and then watch their growth. And that's a very important thing. With hormones, take a long time, and they may take a long time to assess. And sometimes it may take me a year or two to really say, okay, we need it or not need it. And I'll talk about the risk and benefit of growth hormone and why I'm very cautious with it. You may say with Ivy, I went very quickly, but I've seen other kiddos like her, and I saw her growth chart and what was going on, and I was able to collect that data and see what would be beneficial for her. And so that was based on the data I collected and watching Ivy and having the data collected in the endocrinologist prior to myself. I always take a prenatal history. I'm going to want to know what happened with pregnancy. Was it a healthy pregnancy? Was there prenatal care? Are there any chronic disease, any exposure to any toxins, drugs, or anything during the pregnancy, any placenta issues? Of course, family history is going to involve the parental heights, and often we can draw a family tree and figure out heights in both mom and dad sides with the grandparents. Social history, this is where we look at social determinants. Nutrition kind of fits in there too. Dental history, kids with who are not making growth hormone have teeth eruption late. And then we do a full review of systems of how they're currently doing and what's happening. We do sexual maturity rating. And so I told you that kids are going to grow faster during puberty. And as a result, we do this. It's an objective classification system that tracks secondary sex characteristics. And we have tools we use. We have an oxidometer that lets me know the testes hit a certain size. 4 cc's is what we call it here, is when puberty starts. And once we start seeing that 4 cc, we better start seeing that rapid growth rate. And in addition, we look at pubic hair development, we look at breast development in girls. So I'm going to talk to you about the 3 heights or the 3 ages I use. I use bone age, which is X-ray of the left hand that looks at their growth plates and gives me a little bit of their growth potential. I look at the height aged. Anybody's height age is where they would lie on average. For example, your child is now 7, but their height is an average for a 5-year-old, 50th percentile for a 5-year-old. And then with the correct sex, for a male or female, and then compared to their chronological age. Just because their chronological age is a certain age does not mean that they're going to stop growing at 12 or 13, like I showed you. They're not going to necessarily be typical. It's going to be based on their bone age. In addition, the growth rate is very important, and I'll need to watch that growth rate. I really need to see at least 6 months. Sometimes it takes a year to see it because some kids won't grow for a while and then they'll shoot up really fast. So they'll see 0 growth and then really rapid growth, and then 0, that's called stepwise. And every child can have their own pattern. In addition, if a kid got a virus or became ill or had gastroenteritis, the body's going to stop producing growth hormone during that time and deal with the infection or the virus or whatever is going on. And calculate midparental height. But as you know, we take that with a grain of salt. We do use that for sure to give us an idea, but we also know it doesn't necessarily tell us exactly where the child's going to end up. Every child gets a full evaluation from a laboratory perspective. I look for anemia. I look at kidney, liver. I'm going to check for signs of inflammation. That's the ESR. I'm going to look for gluten allergy. Is there some kind of malabsorption issues? Even issues like them not chewing well, not swallowing well. Do they need speech therapy before they can start to do that? Do they need a G-tube? Do they need additional feeding? So you might see us working with the gastroenterologist. We check thyroid function, and then if they're in puberty, we check their hormone levels there. We check growth factors. Those are extremely important. And we may check, we might do genetic referral or chromosomes and that kind of thing, kind of look into that a little more deeply. Bone age is the study of the left hand. I'm going to show that to you in a moment. First, I'm going to show you the different IGF-1 rates. So growth factors are different by age and where they're at and how much they're growing. So you're going to see that I can't just take an IGF-1 level when I measure those. It does not mean that I have to. And honestly, a lot of the labs do not give you the normal correct version for this. So I need to compare it to similar sex and age. And so often I look those up on my own if the laboratory doesn't provide them. And often they do not provide them. The hands have these growth plates. This is where the growth hormone and growth factors work. And they're in, you can see here in the picture, all the different ones. We use the left hand, that's the standard of care. And here's an example of a child, a male at age 8. He's still growing. I call these spaceships. You can see the parts that they can't see. The x-ray goes through the cartilage centers where the growth is happening, versus on the right, a male of 14 that's almost done growing, and the growth plates have fused in this child, which may not be all 14-year-old boys. The pattern is more important than actual percentile. And we look at the 3 ages, the bone age, chronological age, and height age, and we determine the analyzed growth velocity and the midparental height. If all the labs come back normal and the child is still not growing well, we're going to test for growth hormone deficiency. And growth hormone is a physiological response to sleep and exercise and other things. So random growth hormones are not helpful at all, and not necessarily going to tell you what the child's capable of producing. They used to do exercise growth hormone tests. We don't do those anymore, but that you can do that. I use arginine and glucagon are the 2 I use, and arginine is an amino acid, so it's like a nutrient challenge. And the stimulation test basically measures the ability of the child to produce growth hormone. So if they produce less than 5, they have severe growth hormone deficiency. 6 to 9, they're growth hormone deficient, and 10 or above, they're making adequate amount of growth hormone. And if we find that they are growth hormone deficient, we will do a pituitary MRI to take a look at the pituitary and see what happens. If there is some issues there with the pituitary, we might go further and look for genetic testing to look for the deficiency or resistance. So that's very important. And I know with WSS, they have had some pituitary abnormalities, abnormally shaped or elongated. So those have been found in kids with WSS. So growth hormone deficiency is the most common finding with WSS kids. And when you compare those to kids who are producing adequate growth hormone, you find them to be, I don't like chubby, I say under tall. We're not overweight, we're under tall. And so they just haven't hit the right weight for their height yet. Sometimes you can see smaller genitalia, and because it didn't have enough growth hormone, and you can see low blood sugars because growth hormone allows the release of blood sugar from the liver. And one of the things I ask about is, was there a really prolonged jaundice in infancy after they were born? You see with them poor growth rates, and in a moment I went over the normal growth rates with you. You can see delayed bone age, low growth factors, and then you might do the stim test that proved that it was less than 10, and so that they're not making enough growth hormone. This is not typical with WSS, but this is a child with a pituitary tumor that led to the growth hormone issue. So this is this big area here, and this is where the pituitary is. You can see the eyes would be here. And so that's why we always check for that. You can see pituitary deficiency with any child with a midline defect. Sometimes they have a central incisor or a cleft lip or palate. Kids are more likely. There's a condition called septo-optic dysplasia, because when the pituitary forms at the same time as the eyes and the eye nerves form, the optic nerves, and those are associated with growth hormone deficiency. So any child diagnosed with optic nerve hypoplasia, optic issues in regards to the nerve system, we're going to also be sent to endocrinology to check if their pituitary is working properly. Acquired things that can cause it could be like, and this is not seen with WSS, but like a brain tumor, and the most common brain tumor in children are going to be these 3, the craniopharyngioma, glioma, and germinoma, but that is not something that you need to worry about with WSS. Weight and height are really important. If the weight percentile is lower than the height percentile, then growth hormone may not be helpful until we get nutrition up to where we need it. So if your child's weight percentile is lower than your height percentile, we're going to work on upping that nutrition. They may need growth hormone, but it's not going to work till we have a good source of nutrition that will work with that growth hormone. So I will be watching the analyzed growth velocity. I talked to you about measurement accuracy. Sometimes I'll have a measurement from the ED or other places they've been, and they just don't have the same obsessiveness that endocrinologists do. The growth rate and the kid's height is our most important vital sign for us. And so you'll notice endocrinologists are pretty obsessive about proper measurements. We look at all growth charts, and we can look at, there are some growth charts. In America, we're using ones that not necessarily reflect every single race, but we do know that there are different ethnicities have different tendencies. If we can get those, we look at that. And going from a percentile down is a problem, except in those first 3 years of life. And we measure the 3 ages and the mid-parental height estimation. So what about growth hormone for kids with syndromes or genetic conditions? When I recently looked at this, there's more than 1,000 syndromes now or genetic things that have short stature as a component, and not all of them is indicated to receive growth hormone. And many of them we don't know yet. We're still learning. Growth hormone is FDA indicated for certain syndromes, Turner syndrome, which is a CHOX gene mutation, and some kiddos can have that mutation without Turner syndrome, which is a single X chromosome. There's a Noonan syndrome, Prader-Willi, have been shown that the benefit far outweighs any risks and leads to improvement in quality of life. And any kiddo with growth hormone deficiency, whether it's due to a known genetic defect in the development of the pituitary or not. If a child is born small or has had intrauterine growth restriction in the womb, and they don't catch up by age 3, there's a lot of data to show that there is way more benefit in treating growth hormone and helping them grow, helping their body recover from that difficulty in utero. An example of that is Russell-Silver syndrome, does that and is often indicated. And then sometimes we don't know why they're not growing, but the stature is severe and the growth failure is severe as well. And we may not have the typical growth hormone deficiency, but we know that these kids are not growing. And this is the area that I look at with syndromic. Sometimes these kids are just not growing, and we know the benefits of growth hormone, and we know they're getting adequate nutrition. And I am open to trying those when I do know that the benefits are going to outweigh the risks. This is nothing for you to memorize also, but these are all with growth hormone released from the pituitary to the liver to the bones. These are just these are the genetics that we know now, but we keep finding more genes that are going wrong. So this is a story in evolution. I think we have much, much more to know, and we're finding more genetic deficiency and mutations every day. So next I want to talk to you about what are the benefits of growth hormone and why would your child potentially benefit. The first one is functional adult height. If a child is, going to be growing up and working, can they drive? Can they reach cabinets? But more important to me are the stamina, cognition, muscle strength, and bone health, and muscles working better. So the weak muscles get glucose delivered right to them with growth hormone and lead to the growth hormone of the muscles. And I think that's what's happening with Ivy in her gut muscles. Her peristalsis, her constipation has gotten better because the growth hormone has helped her gut muscles grow. I have several patients, and these are, and there are case studies, even big studies in this, because there aren't enough to do, 100,000 patients to look at it, or even 1,000 or hundreds even. But I have seen improvement in motor, language, all sorts of development with the brain growing. And so we have seen cognitive, we've seen kids who don't speak that start speaking. I have definitely seen that with kids. I had a kiddo who had their only chromosome defect, the only person with this 4PQ weird thing, that she was the only, like nobody else in the world had her chromosome deficiency, and she was no growth. I mean, she looked, I think, 3 at age 11. And so I went ahead and I diagnosed her with that severe. She didn't test positive with growth hormone deficiency, but she definitely was severe, and something was going on. We're not sure what. We started growth hormone. She started speaking, and that was exciting. And I got to see her as a teenager. She continued to have big improvement. She walks and speaks and does things that the parents said would never, ever happen. So this is the joy for me to see that improvement. Bones need growth hormone to be strong to prevent osteoporosis. We know that adults need a very, very small amount of growth hormone, and kids need a very large amount to grow. So adults who are missing it completely develop early heart disease and can have heart attacks in their 40s because of cholesterol issues and other issues. So there is a metabolic help with it. Now, if an adult does not have growth hormone deficiency and they take it, what's the problem? And next thing I'm going to talk about the risks that people are taking that I really don't think they should, because it is not the fountain of youth, and it's not the thing that you should take if you want to improve your baseball playing and your professional baseball. And any of those people who have done those growth hormone, they have not been with endocrinologists, I assure you. And they have not done it based on any guidelines. So first of all, if the nutrition issues are not addressed and we're not getting adequate nutrition when you start growth hormone, you can have weight loss, and then the body will pull energy to try to grow, and you may even have frequent infections, or just a child not thriving and not doing well. And so we need to make sure we have the foundation for growth with nutrition. That may involve a G-tube or other things. So until I see that weight at least at the same percentile as the height, I know that we might add extra stress that is not needed for that child. Some kiddos will develop growth hormone antibodies. This is not common, but it's something I watch out for. Like the growth hormone doesn't seem to be working, and they actually made antibodies against the growth hormone we're administering. And we administer human growth hormone. It's the same molecule as our body produces. Also, kids who, I had a colleague of mine kind of treat a kid that I wouldn't have, had a lot of cardiac issues and other things, and they had one arm grow and not the other, and it was very bizarre. And I didn't think that kid would benefit because of all the other complicated things going on. But we know that if you give growth hormone to somebody who's got other things going on and you haven't really double checked and made sure you watched their growth long enough and talked about it, you can cause asymmetrical or strange growth. And I suspect in that child, one growth plate was working and the other one wasn't. And it was a very complicated case of a child that wasn't the typical patient I would recommend treatment in. If you have too much growth hormone or growth hormone in the system more than you need, and it releases too much sugar from the liver, you can get diabetes or insulin resistance or pre-diabetes. We always check blood sugars. I have not seen it in any of the patients I use, but I'm very cautious with checking. I'll do at least once or twice a year lab work where I check blood sugars. I make sure the growth factor level isn't too high. So we're very, very cautious. In addition, too much growth hormone can cause high cholesterol. So you can go the other way. So it's one of those things, too much or too little, both cause problems. It has to be the Goldilocks zone, just the right amount of hormone. And you can think about that with yourself. If you have too much testosterone or estrogen or too little, it has to be just right. You can get high blood pressure. And the biggest thing I worry about is cancer, especially patients with chromosome fragility issues, particularly like, for example, we do use it in Noonans, but we're very cautious. We know that they have chromosome fragility. And I usually will touch base with the experts in that field or with a geneticist to assess if there's any conditions of that. And I don't make that decision. It's something we make as a team, and you live with your child. You know your child better than me. And so also having you watch very closely if we do decide to treat. So communication, watching it. If there are issues, we'll pull back the growth hormone, we reassess. So caution is very important here. There are studies that have looked at WSS, okay? So the recommendations is they all, especially if they're not growing well, that you do assess for growth hormone deficiency, hypothyroidism, and possible metabolic disease. And what I do with that is calcium, phosphorus, magnesium, vitamin D, all the parts of the blood that help with bone health. And it looks like growth hormone deficiency is part of the phenotypic spectrum. In other words, is how kids with WSS can present with growth hormone deficiency. And so if the pituitary is not working, we also need to check other hormones in the pituitary, make sure that, because the pituitary also manages the thyroid and the adrenal gland, and we would get an MRI of the brain and look at the pituitary. And I listed the two most important and most recent studies on this. This one from 2022 just became available. This Shepherd looked at 20, I think from 1993 to 2022. So you're talking about 30 years or 29 years of data on kiddos with WSS. And that's how they came up with the idea that this definitely is something that you can see in WSS. And if something is missing, we should replace it. So caveats, when you're assessing growth hormone, we have to take into inheritance patterns and really watch things a little closer, really assess what happened in utero, know what's going on with that chromosome, really look at their growth rate as opposed to exactly their height percentile. All children are beautiful no matter what height they are. And I really emphasize that the psychological part, really working with your kids on that. There are some data to look at if kids do psychologically better if they're not growth hormone deficient and you treat them with growth hormone, and there isn't improvement in their psychological profile, because I think, in my opinion, it's like saying something's wrong with you and you have to be taller to be better, and there's nothing wrong with them. They're beautiful people as they are. I can't emphasize enough the role of nutrition in growth and how we look at it as functional height. So, for example, for a girl, I'm going to want to get her to 4'10". If we are treating growth hormone, or if we can get them to family height, if that's meant to be, and that works out. And knowing that there are dangers of treating growth hormone if there is not a growth hormone deficiency. Could there be a cancerous growth? In adults, if you have cancer and you get growth hormone and you're not growth hormone deficient, even if you are growth hormone deficient, it's going to cause that cancer to grow. And so it is not the fountain of youth. And I think any endocrinologist and anybody who's looked at the literature and studied this in depth can tell you that it is not a quick fix for anything. And that when you do proceed with growth hormone, that you have a provider who's going to be watching all the things I talked to you about and talking to you about it and having you very involved in that decision. And we can always pull back growth hormone, go forward, recheck things. There is something called pubertal dosing. We dose it on weight and watch their growth and watch their growth factors. So it's always putting in all of it and watching how kids are doing. And we're getting to the end of my discussion. And so I wanted to leave time for questions because I think that's probably the most important part. But I did want to share with you the data on growth hormone deficiency and WSS. And I did want to let you know what a proper growth evaluation by an endocrinologist would be for your child so that you're aware of that and also the benefits and the risks. I thought as a parent, what would I want to know if it was my child? And I based this talk on that. These are my babies. I have 2 boys, and Zachary is the more fair child on the left, and he's my one with autism, and he's now 15, so this is dated. I have to redo the pictures. As you can see, he's making fantastic eye contact with the camera. That's something he significantly improved. These are my references. Otherwise, I put them on the slide. And my last slide is just requesting questions and seeing if I can clarify any questions or help you with any questions you may have about your own child. I heard that clapping. Thank you very much.
Dr. Dajani, that was fantastic. I already knew we were honored and just absolutely blessed to have you in Asheville. And now I just feel even more so. That was just, thank you for your expertise. Does anybody have any questions? I'm going to walk around and hand the mic over. Here we go. There's one right here.
Hi, thank you. I was just wondering, is there an ideal age to start growth hormone? My son is 3 and the blood work has shown normal so far, but I think the next step would be to do a stim test, but we didn't really want to put him through that maybe unnecessarily. So I was just wondering if there was a age you should start by.
That is a fantastic question. So the data shows in other syndromes, the earlier you start, the more likely you get them to closer to genetic potential, especially outside of the height. If you're really having tone issues and you're worried, like not walking because you know it's low tone, or potentially with like the gut, it also helps with smooth muscle. If there's a benefit that's really, really important right now that can be added with growth hormone, if we find there's growth hormone deficiency, we proceed. I also, as a mom, this is where I come in, the best time to put your child through that, mental health, psychosocial. So you got to look at the big picture and say, at this point in time, if we go through this test and put him through this and he starts getting, growth hormone is a daily injection. You do it at night, the way the body produces it. So it's going to be an injection. It's sub-Q. A lot of parents will do it while the kids are sleeping and they don't feel it. It's very, very thin. So, the answer to that is, when is the best time for your child and what are the benefits? And those are things that your endocrinologist can help you look at, but there isn't a magical correct time for anybody. I really am a strong believer in, particularly parents of special needs kids, we know our kids. And I really look at what the family thinks. Is this the right time? I engage the child, sometimes they'll let you know if it's important to them. And I really explain what the process involves. That's going to involve an IV, the stim test. It's going to last 4 to 5 hours. They will numb it up, but it's not an easy test on a child. And if I can avoid it, I try to. And if I have enough data without the stim test, I can proceed. as you know, Medicaid and insurance can be very difficult. I will go to bat. I will talk peer to peer. We will do 4 or 5 appeals if we need to. Unfortunately, often growth hormone is denied, even if it's FDA indicated and you have all the data. And in my kind of skeptical view of it, I think it saves insurance company money if they wait a little. So, but that doesn't stop me or my staff. And so, really, that's a decision. Is, you know, to think about, is this the right time to put my child through this? And are there benefits? You know, is he in a place where I think, or she is going to benefit from this time? And that's not a decision you make lightly. You got to really look at everything that's going on. Lastly, is nutrition been maximized? Have we done everything we can from that perspective? Because if nutrition is not maximized and the weight percentile hasn't got to at least the height percentile, then it's not the right time and we won't get the maximal benefit that we could get.
Great. Thank you so much.
Good question.
Any another question? Coming over here. Hold on.
Hi, Dr. Dajani. I'm actually Ivy's grandmother.
Yay!
It's nice to meet you. I've heard so many great things about you. So I just wondered, I have 2 questions. What happens when you stop the hormone, and when is the ideal time? What happens when you stop the growth hormone, and when is the ideal time to stop? How do you know when it's all gone perfectly and it's time to taper it off?
Wonderful questions. I love this. Excellent.
And I have one more.
Go ahead.
But I just forgot it. So
okay,
it's a
think
long
about
day.
it. While I talk, you can think about it. And if you remember, let me know. Okay, so unlike adrenal gland or other things, if you stop the growth hormone, nothing bad happens. The level in the body of growth factors goes down a little bit and you don't get to that steady state higher level. Nothing bad. People often, kids on growth hormone, if they don't want to take the shots with them on vacation, will stop it. Or if kids are going through something like they're very ill or something, I just say, you know, this is not the time to grow. This is the time to put all the energy towards dealing with that illness, like a really bad flu or stomach situation. And so if the child is, particularly the child has complicated other things going on. And so stopping the growth hormone does not, just leads to no growth. And for its period of time. And sometimes it doesn't even matter because you make up for it and everything's okay. So growth hormone is not one of those that you need to wean. You can suddenly stop it and suddenly start it and nothing bad happens. Okay, the second question is excellent. It is kind of like when to start and when to do the stim testing. The answer to that really is dependent on your child and you. I have had patients where the kids just don't want it anymore. They're happy where they're at and there's still room for them to grow. Once the growth plates close, that's the time to usually stop it and we're not going to get additional growth. So that's the ultimate way we decide. But once again, we look at the child's overall life and what's going on and the family and base it on that as well. So if you wanted to know the hard rule facts is when the growth plate, when bone age shows that you no longer have any room to grow is when you stop. But in addition to that, when the family feels like it's right for them, or if they want to take a vacation, we do that as well. You know, you want to just do a month off or something like that. So excellent questions.
Okay. And did you remember your second question?
My second question was regarding the risk of sleep apnea and having the throat tissue grow and create sleep apnea.
Absolutely. So you can have the tonsillar tissue grow with growth hormone. In addition, however, you're going to have the airway get bigger, but in kids who have tendency for hypotonia or any signs and symptoms, I have a very low threshold. We're doing sleep studies and doing that all ahead of time. If there has been never any evidence of any sleep issues, we could do it concurrently as long as there's really good monitoring. But that is always a good idea with kids with low tone for any reason. So the classical symptom for that we always do a sleep study before we start growth hormone is Prader-Willi syndrome because they have severe low tone. And so that's the indication. They haven't come up with full-blown guidelines for WSS, but if there's any sign of floppiness or the tonsils are already big or there's any sleep issues or breathing issues, then we would wait till we do the sleep study. Sometimes those take a while because it's going to be an overnight sleep study with a pulmonologist involved. And at our center, you always see the pulmonologist to proceed with that. Often you already have a pulmonologist with your WSS kids, so that's something to discuss with them. But in particular, if there's any risk, we should definitely do it.
Okay, I think there are two more questions, and we're going to start the next session at 4:15, just so everybody knows. I don't know who is first. Okay, go ahead.
Hello. I have a 12-year-old son, and we recently visited his orthopedic doctor who did a bone age test. He concluded that he's about 15 years old when it comes to his actual bone, so he's progressed or a little bit more advanced, so 3 years ahead. I guess I'm confused because he actually suggested that we do possibly consider growth hormones, and I was wondering your thoughts, because if he's pretty much done with his growth, why would we consider growth hormones?
His bones will still grow till the bone age is 16 and a half. So I don't know how fast the puberty is progressing, but clearly he's had testosterone enough and he's gone through all the changes. He does have a small window of growth that growth hormone can supplement. And so once again, the risk versus benefit, do you feel like this will help him, that he needs that extra, it might be an extra inch? Is the height worth it, or do you want to do it to see if it can help his musculature? The good news about puberty, particularly males, testosterone will really help increase the muscles and the stamina and the strength as well. So puberty will lead to that, particularly in males. So the answer would be really something to talk to your family and think about, is this going to benefit him? Deciding not to do growth hormone might be the right decision for you, but you definitely have some time right now, but time is of the essence. We don't have much time.
Thank you so much. Okay, one more question. Here we go.
Hi, Dr. Dajani.
Hello.
Hi. So I have a question regarding behavioral issues. Have you seen any association with growth hormone therapy with, behavioral changes?
I love that question, and it comes up all the time. So sometimes people think growth hormone is like sex hormone. It's an anabolic steroid. It is not. It is not even anything like steroids. Steroids come from cholesterol, and they're these big molecules, and it includes estrogen, testosterone, cortisol are all steroids. Testosterone is not, growth hormone is not. And so I have not seen behavioral issues. I can tell you with growth hormone deficiencies, that the kids get stronger. What I see is self-esteem. I've seen them, kids who are truly deficient and weren't growing, and their body started to do what it was meant to do. In general, they're happier. And so I haven't seen negative things. There is some behavior issues with the shot, but we have ways to help with that. We use child life and other things. And generally, once the kids realize they can't feel it, or if you choose to do it while they're sleeping, it is not. So behavioral issues is not a big component of growth hormone at all. Excellent question.
Thank you.
It is with testosterone when we start puberty. I have a whole discussion about as you change, and, estradiol as well. And that's, you see that with puberty, whether we give it exogenously or they make their own hormones.
Time for one more question. Are we wrapping up and going to, I know we have one more session. Thank you so much, Dr. Dajani, and thanks for your time. Thank you for being involved with our Wiedemann-Steiner Syndrome Foundation here, and for presenting to us today. I know this is also going to be on YouTube and shared on our page. So thank you, and hopefully maybe next year we can have you in person.
That would be fantastic. Yeah, unfortunately I was on call, so I couldn't make it there, but it is my pleasure to help other people's children. It's close to my heart, and every time feels like I'm helping my own child as well. Have a wonderful day, and thank you very much.
Thank you. And we do have her contact information if you want to reach out to her by email, or you have any questions. We can put you in touch with her.
Any way I can be of help.